G.
Okay, so for tonight, we're going to discuss about urodynamics. Okay, wait lang. So urodynamics is the general term to describe the measurements that assess the function and dysfunction of the lower urinary tract. So the urinary tract has two essential functions: the storage of urine at a low pressure and the voluntary evacuation of urine. So low pressure storage is essential to protect the kidneys and ensure continence, and voluntary evacuation that allows for the elimination of the urine without leakage or over distension. So for the applications of urodynamics, to obtain information needed to make an accurate diagnosis. So to determine the impact of a disease, then in practical terms, urodynamic is most useful when, of course, may history tayo and physical examination and also simple tests are not sufficient to make sure an accurate diagnosis. So this has a clinical applicability into general scenarios. So yun nga. Then for the role of your dynamics in the clinical practice are the following. So to identify or rule out factors contributing the lower urinary tract dysfunction, for example, urinary incontinence, and to assess their relative importance. The next, to obtain information about the aspects of lower urinary tract function or dysfunction, whether or not expressed as a symptom or a recognizable sign, to allow a prediction or of the possible consequences of lower urinary tract dysfunction for the upper urinary tract. Then to allow a prediction of the outcome, including an undesirable side effects of a contemplated treatment. For example, kung we're planning for a TUR na patient tapos underactive yung bladder, parang hindi pa rin siya mag-benefit sa procedure. So for us to understand fully the pathology behind the urinary symptoms, we need to have a background of our nervous system, which controls the functioning of our lower urinary tract. So for the cortical center, at the pontine region, so pag may problema sa cortical areas, usually it manifests as storage symptoms. Then for the brainstem, uh, sa ano to, sa micturition naman siya or predominantly sa emptying. Then for the neural control, in the bladder we have receptors and also in the external and internal sphincter. So for the bladder we have muscarinic and beta 3 receptors. So three most important efferent nerves involved in the lower urinary tract are the following. So for the pelvic, it is a parasympathetic, so hindi not in our control. It releases acetylcholine that binds to the M3 receptor, which causes the contraction of the detrusor muscle. So next is the hypogastric nerve, which is sympathetic. It targets two things, no? So first, in the detrusor muscle and the for the detrusor muscle, it causes relaxation by binding to the beta 3 receptor. Then for the internal sphincter, it causes contraction naman. Then next is the pudendal nerve or the somatic, meaning it is in our control. It also releases acetylcholine, which binds to nicotinic receptor found in our external sphincter. So when acts on the nicotinic receptor, it causes sphincteric contraction. So there's a fourth nerve, which is a sensory pelvic nerve coming from the detrusor muscle. So usually, na-activate siya pagka stretch yung bladder natin. So for the essential urodynamic test, there are three, no? Uroflowmetry and assessment of the post-void residual, filling and voiding cystometry, and bladder diary. So First, uroflowmetry. This is a test that measures the urinary stream as volume passed per unit in time in milliliters per second. So uroflowmetry is a non-invasive urodynamic test in which specific measurements are made of the rate of flow of urine and the volume voided. So for the preparation, bladder diary also captures the symptoms and events such as fluid intake, urgency, pain, incontinence, and average and maximum voided volume, voiding frequency, and urine production at night. So, kailangan may bladder diary siya as much as possible pag magpe-perform tayo ng UROFLOW or urodynamics. So, it is also important to have a baseline urinalysis as indicated by screening. Microanalysis and culture should be performed that may provide a guidance regarding further testing or therapy for the conditions related to independent or urinary incontinence. So, dapat ma-roll out natin na walang UTI yung patient kasi pwede siya magkaroon ng effect dun sa magiging result natin. So, for the equipment, an environment, a suitable environment of uroflowmetry is a must. So the uroflowmeter can be accessed quickly from the waiting area if the patient experience urgency. And then also dapat may privacy yung patient. Then dapat may curtain na division between the machine and the commode or the kung saan sila mag-void. So it is also important na i-instruct natin yung patient na dapat void sila pagka ihing-ihi na talaga sila. So it is important lalo na pagka nagpe-perform tayo ng uroflowmetry kasi minsan yung patient hindi pa talaga sila ihing-ihi pagka mag-ano na sila, mag-void na sila. So dapat maganda yung instruction na ibibigay. So the normal flow curve is a bell-shaped pattern and the flow rate varies according to the volume voided. So if a voiding is slow, so then it appears a vertical line pattern compared when it is faster, which is an elongated. So when the flow is reduced or the pattern is altered, this could indicate dysfunction of the bladder or Detrusor Underactivity or a bladder outlet obstruction. Then it cannot definitely identify specific underlying abnormalities of the detrusor pressure data. So dapat magpo-proceed tayo sa urodynamics after a uroflowmetry. So in particular, there are no definite normal ranges for Qmax, although it decreases with age and voided volume, but not in directly proportional manner. So mamaya papakita ko ng chart na nag-vary sa Qmax. So so for the voided volume, at least 150 ml above. Pero sometimes for example, paulit-ulit siya nag-void less than 100. Kung yun lang talaga yung bladder capacity niya talaga, by makikita natin sa bladder diary niya, so baka yun lang talaga yung kaya niya. So for the Qmax, for the flow rate, if below 10 ml per second, so it's abnormal. So if it's above 15 ml per second, it's normal. So this table shows yung normal with relation to age group, no? So for the male, for 16 to 50 years old, yung maximum flow rate niya is at least 22.8 ml per second. Then if the patient is above 50, at least 17 ml per second. So with the average flow rate of 13.22 for and then 8.9 ml respectively. So for the female naman, for the premenopausal, 21 ml per second, and then for the postmenopausal, menopausal, 10 ml per second. So, ito yung sa pediatrics naman. So, for the patterns, yun nga, yung normal flow natin is bell-shaped curve. Then, next, for the decreased flow, this is the blue line. This is the most common abnormal flow trace seen in patients in practice and represented by a dampened curve with a decrease in Qmax and prolonged flow time. So significantly decrease yung Qmax niya. So most probably less than 15 ml per second cannot be used to distinguish between bladder outlet obstruction or impaired detrusor contractility. So kailangan pa rin natin mag-urodynamics. So for the plateau flow, itong orange, this one, a long flow time associated with poor flow is typical for a stricture in the lower urinary tract. Another commonly encountered scenario is the patient with, for example, post-radical prostatectomy incontinence. Then for the intermittent flow, ito. This may be seen in patients with who void with some abdominal straining due to bladder outlet obstruction or poorly contractile detrusor muscle, and often superimposed on a decreased or plateauing curve pattern. So next pattern is the sawtooth. So ito yan. Parang nag-waveform siya. So often a pathognomonic sign of a detrusor sphincter dyssynergia. So it means uncoordinated movement or contraction of the sphincter. So this curve should prompt an urgent pressure flow studies to investigate a high intravesical pressures that might damage the upper tracts. Next is the supervoider. So for the supervoider, itong mataas. So this is seen in patients with surgery for post-surgery for bladder outlet obstruction. For example, post-TURP or urethroplasty. So in patients with decreased urethral resistance and sphincter deficiency, or occasional in those with detrusor overactivity. So sometimes we encounter also artifacts. For example, this one. Ito yung normal pattern niya, but we can see a peak here. So, ang nangyari dito, the patient squeezes his urethra and then releases abruptly, causing a spike in the recoil of the urethra. So, next essential urodynamic test is the bladder diary. No? So, a bladder diary, this records the times of micturations and voided volumes and additional information appropriate for the individual being evaluated. So it could include incontinence episode, fluid intake, and then degree of urgency. So ito yung example ng bladder diary. So it is important na at least may bladder diary yung patient because during the examination or the test, pwede natin i-correlate yung symptoms niya. For example, may incontinence talaga siya during the sa bladder diary niya. So, at least mako-correlate natin. So, for the ICS standard, in urodynamics protocol,
Ernest?
Yes, sir.
Ano pa yung significance sa uroflowmetry? I mean, dun sa bladder diary. Other than yung sinasabi mo ng incontinence, what other information can you get? Basic information that you can get.
Wow,
Sir, pwede rin tayo, sir, makakawa, sir, na ano, ng yung kung gaano kadami yung output niya. Then, kung for example, small bladder capacity din niya, kung may small bladder capacity siya, kagad siya mag-void after mapuno na po yung bladder niya, sir.
Okay, so basically, you will be able to get the bladder capacity of the patient. So from there, kunyari, magagawa ka na ng urodynamics. kasi nag-bladder diary ka na eh. So usually ang requirement before you do a pressure flowmetry, you do a bladder diary.
Yes, sir.
So pag meron kang bladder diary, makita mo na yung capacity niya. So pag nag-urodynamics ka, 'di ba nagbibigay tayo ng fluid, ng
Yes, sir.
inflow. So yun yung alam mo yung parang pinaka ini-expect mo na yung time na yon na magkakaroon siya ng pakiramdam ng urgency or first sensation or the normal sensation to void.
Yes, sir. Thank you, sir. So next is the feeling and voiding cystometry. So for the pressure flow study, it is a study of pressure and flow against a resistance. So this describes the measurements that assess the function and dysfunction of the lower urinary tract. So kailangan low pressure storage is essential to protect kidneys and ensure continence and voluntary evacuation that allows the elimination of the urine without fear of leakage or over distension. So for the urodynamics, the purpose are the following: to reproduce the patient's symptoms and correlate with your urodynamic findings, and also to assess the bladder sensation, to detect Detrusor overactivity, to assess urethral competence during feeling, to determine the Detrusor function during voiding, and assess outlet function during voiding, and measure the residual volume. So there are four diagnoses of urodynamics. First, we can diagnose if the bladder is overactive during feeling, incompetent urethra during feeling, if may incontinence yung patient, then underactive detrusor during voiding. So makikita natin kung may residual siya. Then obstructed urethra during voiding. So for the classification of lower urinary tract dysfunction, so it is the most important concept to understand when trying to set up or conduct a urodynamics. So for the storage dysfunction, we can diagnose if the patient has a failure to properly store the urine. And for the emptying dysfunction, we can also diagnose if the patient has a failure to empty the bladder normally or in combination. So for the functional abnormality based on anatomy, bladder dysfunction or underactive. For the bladder outlet dysfunction, overactive or underactive also, and then in combination siya. So during the orientation, bago mag-start yung test, it is important to provide instruction to the patient. So we can give a list of problems or questions that should be solved or answered during the test. So kailangan kasi during the urodynamic kasi may mga instruction dun sa patient. For example, kung first sensation niya, hindi siya dapat iihi kaagad. Basta may staging siya na kung ihinat siya talaga, dun lang siya, for example, mag-void. Then, patient's preparation, we can do urinalysis and antibiotic prophylaxis because this is an invasive procedure. Mag-insert tayo ng mga catheter sa both urethra and sa rectal area niya. So for the facility setup, in addition to the technical aspects of urodynamics, so the room setup is also important. Ideally, a room is of suitable size should be dedicated to the urodynamics. So this area does not have to be exclusively for urodynamics, but when a study is being performed, there should be no distraction from the people walking into the in and out of the area for other reasons, and dapat may privacy. So for the preparation for the urodynamic machine, so gently place the catheters. So we have two catheters, the urethra catheter and then the rectal uh, catheter, yung parang may probe siya. So for the calibration, ito yung pinaka-importante na kailangan makalibrate natin yung machine and then zero the pressure of the with the atmosphere. So before we start, dapat naka-calibrate siya and then naka-zero yung lahat ng pressures. So we have to check all the transducers kasi minsan madali lang siya matanggal. So we must secure kahit tape lang dun sa inguinal area para hindi siya matanggal during the examination. So for the calibration, ito yung two syringes. It's used to flash for example, kung may bubbles yung tubings and para ma-flash out siya. So, nakita ba? Ayan. So, ito yung machine natin sa office. We have to click this one, zero all. So, by clicking the zero all, it will set all the pressures to zero to the atmosphere so that we can see the resting pressures of the bladder and the abdomen, which is above zero. So, for example, ito. So, dapat naka-zero siya so that pag nag-start, we can see all the resting pressures of for example, the vesical pressure and the abdominal pressure. So actually, hindi siya talaga zero. But the detrusor, dapat almost zero siya. So for the essential measurements, ayun nga, intravesical pressure, the PVES, abdominal pressure, the PAB, and then the detrusor pressure, which is equivalent for PVES minus the PAB. Then the urine flow rate, which represented by Q, and then the bladder volume, which is P. So PAB and the PVES are similar and above 95% lies in the following. So it depends on the position of the patient. So kung standing position, dapat 20 to 50 centimeters per water yung pressure niya. So this is the urodynamic equipment. So this is the commode. Then ito yung machine natin. So this is the transducers, no? Ito yung sa urethral catheter. Then this one, the transducer, ito yung nilalagay sa rectal area. So during the filling and storage phase, filling pressure sensation, involuntary contraction, and detrusor activity, when analyzing and interpreting the urodynamic, it is useful to separate into filling or storage phase and voiding phase. So this allows for ease of classification of urinary tract dysfunction according to functional classification system mentioned earlier. So dapat two stages siya, filling and storage phase, and then normal filling and storage. So these are the normal curves of the urodynamics. So this is the vesical pressure, the abdominal pressure, and then the detrusor pressure.
Teka, balik ka doon.
Yes, sir.
Ano yung significance ng bawat yan? Paano mo, sabi mo ito yung normal curves. So how is it normal?
So during, for example, this is the voiding, if we instruct or if we give the patient the permission to void,
Sorry. Ano tong graph na to? Is this filling or voiding?
Voiding ano na to, sir? And then, ito yung ano talaga to, sir. From filling and voiding, sir. Ito yung voiding area dito, sir.
Yung nasa taas.
Yung nataas, sir, ito yung flow.
Ano yung
So,
significance ng
during...
mga spike dun sa...
So, these are the... Ito yung, ito yung, for example, at 10 time or during the test, we can instruct the patient to cough. So ito yung mga pressures na tumataas during stress. So dapat wala siyang incontinence dito na makikita. So yung detrusor pressure, usually pag tumaas yung detrusor pressure, dapat tataas din yung vesical pressure without kahit during voiding pala, sir, hindi maapektuhan yung abdominal pressure. So during voiding, ito yung time voiding line niya. So opening of the sphincter, sir, ito. So dapat with the detrusor and the vesicle. Tapos mag-flow na yung... So this is the urine flow. Pabagsak na siya, sir.
Ano yung significance dun sa PDET dun sa baba? Yung sa left side ulit.
Saan, sir? Dito?
Left side. Sa baba. Sa yung PDET.
Ito, sir.
Yan, oo.
Yung significance, sir, ng detrusor these are sir, pwedeng to, sir, overactivity, sir.
No, hindi siya overactivity. Diba, normal nga siya eh. Sabi mo normal, bakit siya magkakaroon ng overactivity?
Ay, sir, incongruent siya, sir, dun sa stress na ibinigay natin. For example, nagpaka...
Eh, di ba dapat 0?
Yes, sir.
Bakit may spike?
Pwedeng overactive bladder, sir.
Normal nga yan eh, normal. Hindi pwedeng overactive. So, normal siya. Kung normal yan, walang
walang spike, sir.
Hindi, tama pa rin yan. Normal pa din yan. Kung inaano mo, dapat wala siyang overactivity. So, kung hindi overactivity yan, ano yan? Ito kasi naiintindihan mo yung graph. Kasi sabi mo normal eh. Okay, sige, normal. Payag ako na normal. Ano yan? Ano yung spike? So, ang itsura ng spike, kasi medyo malabo yung video mo dito eh. Anyway, yung spike na yan, di ba parang up and down yan, di ba?
Yes,
na magkahiwalay. Magkahiwalay yan, di ba? Okay. So, supposedly, what is PDET? PDET is equal to?
Equal to the vesical pressure, sir.
Yun lang?
Hindi, sir. PDET, sir, is sir? Vesical pressure minus the abdominal pressure.
P minus P-ab.
Yes,
so, kung dapat same lang yung pressure na to, dapat 0 to, di ba? Dapat flat. Pareho dapat nung Q. Pero bakit meron siyang up and down?
Hindi ko maano, sir.
Hindi. Sige, sagutin ko na lang. Kasi meron niyang delay. No? So, pag umubo ka, anong unang mangyayari?
Mag-spike, sir.
Tapos, magkakaroon ulit ng negative pressure. So, nagkakaroon ng delay yung transmission ng pressure doon sa pinaka antag dito, yung sensor. So, ang nangyayari, up and down yung galaw. Okay? So it's still normal. So kaya 0 pa din 'yan kasi nagne-negate silang dalawa. Pero na-detect nila may nauna lang na isa bago yung pangalawang pressure. So up and down. Kaya gumanon siya.
Mhm.
Okay? Hindi siya yung parang tuloy-tuloy na flat lang. Okay? So may reason 'yan bakit ganon. So that's the same thing. Kunyari pag nag-check kayo tapos hindi gumagalaw yung PDET nyo, there is
Yes,
something
sir.
wrong. Okay? So yun yung mga kailangan alam nyo pag nagto-troubleshoot kayo ng urodynamics. Yung cause ng delay, actually, yung sa sensor lang yun, yung pag-ubo ng patient mismo. Eh, walang ano yun, yung basta yun yung ano pag-ubo tapos parang pag gumanon siya, 'di ba? May negative, positive, parang ganoon.
Yeah,
So,
yeah.
pag ubo niya, biglang babalik sa negative.
Yes, sir.
Tapos magfa-flat siya ulit.
Yes, sir.
Okay? So, yun lang yun. So,
Okay.
it's still normal. Huwag mong sasabihin na overactive kasi dinidiscuss mo nga normal siya na
Yes, sir.
curves.
Thank you, sir.
Okay? Okay.
So, interpreting pressures changes during the urodynamics. So, during detrusor contraction, there's an increase in vesical and detrusor pressure. However, there's no increase in the abdominal pressure. But in straining, laughing, or all other causes of raised abdominal pressure, there's an elevation of the vesical pressure and abdominal pressure, except for the detrusor pressure. Then for the rectal contractions, there's only a rise in the abdominal pressure without elevation of the vesical and then the detrusor pressure. So normally, detrusor pressure should remain near 0 during the interfilling cycle until voluntary voiding is initiated. So the bladder must remain at low pressure storage until the patient give the command to void. So itong graph na to, yun nga, during feeling, near 0 yung pressure ng detrusor muscle. So until dun sa voiding phase na. So bladder voiding efficiency, this only is a measure of the bladder emptying. So it is equals to voided volume over the total bladder capacity times 100. So for the total bladder capacity, it is equals to voided volume plus the post-void residual. So detrusor overactivity and impaired compliance. So detrusor overactivity, it is involuntary detrusor contractions during feeling phase. So it is associated with urgency and even urgency incontinence. And then contraction is involuntary. So incontinence may be spontaneous or provoked. For example, these two spikes, magkukos siya, these are example of detrusor overactivity during feeling. So, if we have, kung may dun sa flow ng dun sa outflow, kung may makita tayong spike, at the same time na tumaas yung pressure ng detrusor muscle, it is considered incontinence siya pag may flow ng urine. So, impaired compliance. So, compliance is the relationship between the change in bladder volume and change in the detrusor pressure. So, it is measured in ml per centimeters water. So, the normal is 46 to 124 ml centimeters water. So, if it is below 20, ibig sabihin impaired compliance siya or non-compliant bladder. So, in this graph, note that the rise in the PVES and PDET with bladder filling. So the PDET at the end of filling is approximately 45 centimeters water, so which is a potentially dangerous situation. So in this case, the bladder was filled to a volume of 300. So the compliance is 6.67. So less than 20. So impaired compliance siya. So i-divide lang natin yung volume dun sa PDET niya. So 300 divided by 45, it's 6.67. So this is an example of bladder overactivity. Itong mga spikes na to. So we have also what we call the bladder outlet obstruction index. So it is equals to PDET at Qmax minus 2 Qmax. So if it is above 40, it means obstructed. So but the equivocal is 20 to 40, and then if it's below 20, unobstructed. So this is an example of bladder outlet obstruction. So it shows that the PDET at Qmax is 87. Dito siya. So ito yung Qmax, PDET at Qmax niya. 87. So minus 2 times 7, 40. So it means obstructed yung patient na to. So Detrusor overactivity and impaired compliance. So for example, this one during feeling at 400 ml, pressure niya is 50. So yung compliance niya is 8 ml, so non-compliant siya. Parehas din dito. Small bladder lang yung, kumbaga small bladder capacity. So leak point pressure. So the leak point pressure is the pressure, spontaneous or provoked, that has caused the fluid to be expelled from the bladder. So during increase in detrusor pressure, tapos magkaroon ng leakage ng urine, so yun yung leak point pressure niya. So abdominal leak point pressure after a progressive Valsalva maneuvers, leakage is demonstrated on the last one at 109 centimeters water.
Saan nakikita yan, ano na yan? During
Alin,
what
sir?
part of the test? Yung leak point pressure.
Sa ano, sir, kung tayo, sir, cuff test tayo, sir.
So, saan part? Anong phase?
Sa feeling, sir.
Yun, sa feeling ha. Hindi mo siya makikita dun sa voiding phase.
Yes, sir. So, stress-induced detrusor activity. In this case, there are 3 episodes of detrusor activity preceding 2 episodes of stress-induced detrusor activity, or SIDO. So, in this case of stress-induced detrusor activity, we can note that the abdominal pressure is increased. So does the PVES. So ito yun. Shortly after this, the PDET rises and continues long after the abdominal pressure returns to baseline. So with both episode of stress-induced overactivity, incontinence, and as can be seen on the flow. So ayun. So it is important na kailangan i-mark na i-label natin kung yung taas nung ano natin nung graph. For example, this one this is a indication for detrusor overactivity with incontinence. So mayroon siyang incontinence dito. Incongruent siya dun sa detrusor muscle and then the vesical pressure. So this is overactivity with incontinence. So for the bladder contractility index, it is equals to P det at Qmax plus 5 Qmax. So if it is above 150, it means the patient has strong contractility. Then 100 to 150, normal contractility. Then if it is below 100, weak contractility or Detrusor Underactivity. So for the Detrusor Underactivity, it is a contraction of reduced strength or duration, resulting in a prolonged bladder emptying or failure to achieve a complete bladder emptying within the normal time span. So a contractile detrusor occurs when there is no demonstrable contraction during urodynamics. So this is a urodynamic tracings of a male patient with the detrusor underactivity. So during voiding phase, the Qmax was 8L, and then the P det at Qmax was 30. So that's 288 ml, and then there is 70. So upon computation, the contractility index was 70. So it signifies a detrusor muscle underactivity. So 30 plus 5 times 8. So kaya 70 siya. So during voiding and emptying phase, it examines the emptying phase of the micturition. So low or normal detrusor pressure and high or normal flow rate. So it means normal or unobstructed voiding. So if the detrusor pressure is high and then low or normal flow rate, it means obstructed. Then if the detrusor pressure is low with a low flow rate, it means underactivity. It means detrusor underactivity. So the voiding pressure flow study, it helps to assess two critical parameters related to the bladder and bladder outlet, which is the detrusor activity and outlet resistance. So madidetermine natin kung obstructed or unobstructed yung patient. So for the neuromuscular dysfunction of the lower urinary tract, these are the following disorders. So if the patient has CVA, pwede magkaroon siya ng overactive detrusor muscle, and then pwede magkaroon ng normal compliance. Then for the smooth sphincter, then straightened sphincter, synergia or dysynergia. So ito yung sample ng mga disorder. So ayan. Pagka spinal cord injury, pwedeng areflexic, then normal yung compliance niya, or tapos sa sphincter naman, fixed yung tone niya. So miscellaneous conditions definitely or probably or possibly related to neuromuscular dysfunction. So yeah, detrusor sphincter dysynergia. It is a kinesiologic dissociation of two groups of muscles that in general work in harmony. So sphincter dysynergia is an involuntary contraction or lack of relaxation of either the straightened sphincter or the smooth muscle sphincter. So it happens in patient with spinal cord injury, multiple sclerosis, or transverse myelitis. So the common treatment are the following. Clean intermittent catheterization, which is usually combined with therapy to control the detrusor activity. We can do also sphincterotomy, injection of botulinum toxin A into the sphincter, or urinary diversion. So for the OAB, It is a urinary urgency, usually accompanied by frequency and nocturia, with or without urgency, urinary incontinence, in the absence of urinary tract infections or other obvious pathology. So the syndrome of overactive bladder is based on the symptoms in contrast to Detrusor activity. Is a urodynamic observation characterized by involuntary detrusor contractions during the feeling phase, which may be spontaneous or provoked. So for the management of OAB, the first line are bladder training, bladder control strategies, pelvic floor physical therapy, weight loss, and fluid management. We can give also anti-muscarinic agents as well as beta-3 agonists. So for the third line of treatment, we can do tibial nerve stimulation, sacral nerve stimulation, and intravesical botulinum toxin injection. So for the fourth treatment, we can do surgery, which is augmentation cystoplasty. For the underactive bladder, it is a contraction of reduced strength and or duration resulting to a prolonged bladder emptying or failure to achieve a complete bladder emptying within a normal time span. So underactive is characterized by a slow urinary stream, hesitancy, and straining to void, with or without feeling of incomplete bladder emptying. So these are the etiology. It can be idiopathic, neurogenic, iatrogenic, or pharmacologic. So for the management, we can do conservative therapy, yung pelvic floor physiotherapy and biofeedback. So for the pharmacotherapy, we can give parasympathomimetics, alpha adrenoreceptor antagonists. We can give also botulinum toxins and surgery. So yun na po yung last slide, sir.
Gising na daw, sabi ni Ernest.
Ano na?
Gising na.
Slides mo medyo
Pixelated, Ernest?
Pixelated ba?
Oo, kanina pa. Naka-dial up kaya taboy?
Hindi. Naka-ano ako. Naka-net ko sa cellphone.
Okay, kita naman yung mga big graphs. Pero yung mga initial slide mas malabo.
Question.
Yes, sir.
Yung mga common tawag dito, may mga diseases na common na dapat alamin mo rin. Like for example, diabetes. Ano ba ang isipin mo doon? Parang wala kang binanggit about diabetes. Describe the urodynamic findings for diabetes. Ano ba ini-expect mo?
Usually, sir, underactive, sir.
So, sige, i-describe mo urodynamics mo. What will you expect in a diabetic bladder?
Diabetic with BPH.
Ano, sir?
Yes, syempre, sabihin mo, for TURP, yun pala may 5-year history ng diabetes. What would you expect?
So, we can expect, sir, Detrusor muscle underactivity, sir. So,
kunyari, describe mo, ano ba yung feeling phase? Ano mangyayari? Ano mangyayari sa voiding phase? Describe mo. From PDET. Kasi syempre, ito yung mga common diseases na encounter mo eh. So, actually, ito yung mga patients na pinapadala ko sa iyo. Ano ba ini-expect mo dapat
sir, makikita natin na with a large amount of volume infused, sir, pwede niya hindi siya maka-feel, sir, na feel of sensation to void, sir. Then there's during voiding phase naman, sir, yun nga
hindi, yung ano yung muna sa feeling phase, wala siyang sensation.
Yes, sir. Pwedeng
What do you
wala.
expect? What do you expect dun sa bladder capacity?
Increase.
Ano expect mo? Anong pressure sa detrusor? Anong pressure ng pelvis?
There's an increase, sir, in there's an increase in the PVES and pwedeng decrease yung PDET niya or hindi siya mag-rise, sir, due to the underactivity ng detrusor muscle, sir. And there's also a large bladder capacity na pwedeng makita dun sa feeling phase.
So mababa ang
PDET, sir.
PDET,
Mababang
PVES.
PDET, and then the vesical pressure elevated, sir, due to the brought about by the volume, sir, na na-infuse natin. Kasi magiging large bladder capacity siya eh.
If you're expecting a low PDET, diba sabi mo PVES minus PAB is PDET.
Yes, sir.
O anong dapat expect sa PVES? Mababa rin.
Mababa, sir.
Diba?
Yes, sir.
Saan mo titingnan yon? Sa feeling phase o sa voiding phase? Yan lagi. Kasi, example, yung sinasabi ni Dr. Alpas, so, the patient is for TURP. The patient is, so, ang, supposedly, the patient will come in, in retention. Ganun ba usually, sir, yung pinapadala mo?
Retention. Oh.
Retention. Oh. So, ano ang kailangan mong, so, dalawa, paano ka, i-apply natin yung inano mo,
Yes, sir.
yung ni-lecture mo. So, dumating yung pasyente in retention. So, ang plano ni sir, iti-TURP niya yung patient. So, i-unobstruct niya.
Yes, sir.
So, ngayon, ano ang kailangan mong tingnan na function niya? Feeling ba o voiding?
Sa voiding, sir.
Sa voiding, okay.
Yes,
ngayon, ano yung ine-expect mo? Yun yung sigurong inaano ni sir. Ano ine-expect mo ngayon sa voiding niya para masabi natin na magiging effective ang TURP sa kanya?
Dapat, sir, wala siya or minimal yung post-void residual niya, sir.
Hindi. Doon tayo sa doon sa urodynamics nga, yung PDET niya, tsaka yung PVES, tsaka yung PAB. Ano yung mga values na ine-expect mo? Pag nag-void siya, pag siya, dinetermine mo na sa pressure flowmetry mo.
Yes, sir.
Pwede mag-start mo rin tayo sa feeling.
Sa feeling, sige.
Sensation. Ano ba ang first sensation? Ano ba ine-expect mo? Meron sensation o walang sensation? Paano kung sensation?
Diabetic, sir?
Hindi,
dapat wala siyang
sensation.
delayed sensation sa sir with a large...
At what volume? Volume of first sensation, volume of... Yun. Paano kung first sensation niya is 300 ml? Normal ba yun?
Non-compliant, abnormal yun, sir. Pwedeng non-compliant yung bladder.
No, hindi non-compliant. Compliant na sobra kasi ang taas na nung value nung volume mo eh. 'Di ba? So sobrang compliant. So ibig sabihin wala na nga siyang nararamdaman. Lumalaki na yung bladder niya, hindi niya nararamdaman, 'di ba?
Yes, sir.
So anong dapat kung yari diabetic, so dapat
large bladder capacity, sir.
Hindi.
So when will you say na pwede mo siya TURP? Una, anong volume? Sabi mo large bladder capacity pag diabetic. So, paano mo ngayon masasabi na pwede mo siyang i-TUR na normal siya? At what feeling phase? Anong volume na dapat may
sir, at least 150, sir.
Yes. 150. Kasi pag lumampas na yan, 300, 500, mag-iisip ka ngayon. Diba? Ay parang mabagal yata ang sensation nito. Large capacity bladder pa. So mag-iisip ka na doon. Diba? Doon pa lang sa feeling phase. Okay. O kanyari, nasa ano na siya, yung magvo-void na siya. At what volume are you expecting na dapat mag-start na siya may sensation to void?
Yung may urgency na nihe.
At least, sir, 500, sir, yung at least 500, sir, yung volume. Yung ihihin na talaga siya.
Yun na yung maximum.
Kasi, sir, depende sa patient, sir, eh.
Hindi, sa common nga, yung usual, yung normal. What's the normal bladder capacity? Yun na. What's the normal bladder capacity?
Usually, sir, 500, sir.
Usually 500.
So pag nasa 1,000 yan, mag-isip ka na rin.
Yes, sir.
1,000, parang yung palang may urge to urinate. May bladder feeling defect talaga siya noon, di ba?
Yes, sir.
Okay. Doon tayo sa voiding. Ano expect mo sa voiding?
So, sa voiding, sir, pagka underactive yung bladder, matagal yung voiding phase niya, sir. And then flattened siya or nagdadampen yung line nung outflow.
Ano yung pag diabetic, ano dapat yung Qmax nun? Mataas, mababa?
Pag diabetic, sir. Usually, sir, mababa, sir.
Mababa. Ano
Yes,
yung
sir.
expect mo dun sa PDET max?
Describe mo lahat. PDET, PVES, PAB. Ano makita mo?
Sa PDET, sir, usually low yung detrusor pressure, then abdominal pressure, sir, elevated, pati yung vesical pressure, sir.
Elevated? Pag pag ina-expect mo na na iihi siya.
Iihi siya, sir.
Hindi, normal voiding lang muna.
Sir, pagka sa diabetic na patient?
So, when do you expect na maganda ang voiding niya? Ano ba, what PDET ang hinahanap mo? Okay, pwede ito. Pwede natin TOR.
At least,
Sige. Nandun na, tama na yung first letter mo. Tama na. Either 40, 50, iba-iba. Ano yun?
Kasi nabanggit mo na kanina eh. I-review mo lang eh.
Ulitin mo lang yung dinis.
Kanina yun eh.
Sabihin mo lang ulit. Kasi ina-apply natin kung ano yung, kung naiintindihan mo talaga yung diniscuss mo. Kasi ano yan eh, ma-apply niyan sa mga patients na diniyo.
Karaniwan naman kundi man diabetic, stroke patient, mga ganyan.
Exactly. Yun nga eh.
Ano yung gusto ko kasi malaman, paano mo masasabi na pwede mong operahan to at magkakaroon ng effect sa kanya kasi syempre pag 'di ba ang pag-ihi naman ano lang ba 'yon o sa obstruction lang ba tinitingnan?
Hindi
'di ba? Meron siyang yung dadaanan which is yung obstruction, meron din yung nagpo-push which is yung bladder. So ano yung mga ini-expect mo dun sa area?
Dapat, sir, yung detrusor pressure, sir, at least yun nga, kung sa normal, sir, at least 46 to 220.
Sa PDET
Sa
yun.
PDET.
Sa PVET.
And then, same din sa PV kasi parehas sila.
Yung PAB.
Hindi siya mag-riser. Yung dalawa lang, yung PVES lang and then PDET related. Kung tataas siya, dapat mataas din yung PVES.
Sige, what can you do? You think na ano pwede mo gawin sa patient? I-ask the patient to do para malaman makaihi siya.
Ano, sir?
What will you ask the patient? Anong maneuver? Makaihi din siya. If you're thinking about kunyari, yun na, Valsalva. Di ba? Pag nag-Valsalva ka, minsan makikita ng effect yung PAB.
Yes, sir.
Sa PDET and the PVIS. Kung may reaction yan yung tatlo, di ba?
So, anong...
Anyway, so, tapos, expect sa flow.
Hindi ko ma-gets yung tanong, sir. Sorry.
Sa, voiding na. Nasa voiding phase na tayo. So, pag may bladder, underactive bladder, ano may expect mo?
Ano yung PDET?
No. Sa UROFLOW. Voiding na tayo, voiding.
Tapos, underactive yung bladder.
Anong mangyayari? Makakaihi ba siya? Hindi siya makakaihi? Ano yung mga ini-expect mo na dapat?
Slow, sir, yung sir, during voiding phase, sir.
Mahina ang walang
Yes,
flow.
Sir.
Okay. Pero yung PDET niya, nabababa pa rin. Kailangan tumaas yung PDET and PVIS para makita mo kung merong bladder contraction, di ba?
Yes.
Maski walang flow. Habang nagvo-void siya, ni-expect mo dapat tumataas ang PDET mo para malaman mo nga maski na walang flow. Kasi baka sabihin mo, ay walang flow. So, sabihin, siya, hindi siya makakaihi. Sabihin, may obstruction pa rin. Pero, titingnan mo pa rin kung nagpa-function ba o hindi.
Okay.
Function yung PDET, tas walang flow, may bladder function ka. So, obstructed pa rin siya. Okay.
Yes, sir.
Pwede bang kunyari, saan mo nakikita ang Detrusor Overactivity?
During
Anong
feeling, sir?
Feeling. So, pwede bang pwede ka bang makita ng patient na may overactive bladder tapos in retention?
Overactive bladder.
Tapos hindi siya makaihi.
Pwede, sir. Sa patient, sir, na sir, yung may mga neurologic problem, sir.
Hindi, urology nga to eh. Kaya nga Hindi,
Bakit mo na kanina yun actually?
Mayroon ganon, may combination, no? So there are cases that when a patient has overactive bladder but has bladder underactivity when voiding. So kasi magkaibang phase 'yon. Pwedeng dalawa yung sakit niya, which is very difficult to treat kasi hindi mo alam kung ano ibibigay mo. Pero pwede 'yun, ha? Sa graph.
Hindi mo nakakita sir ng ganun, sir. Di ba na?
Kailangan medyo talaga kasi si Urodynamics, talagang ano yan, kailangan talagang naiintindihan nyo yung parts nung graph para ma-interpret nyo siya ng mas di siya yung ano, kasi tulad niyan, di ba, nagdi-discuss ka, I'm sure binasa, kaya ginagawa namin, pinapa-apply namin sa iyo sa isang page para kung naiintindihan mo yung ano, yung pinaka ibig sabihin ng sasabi mo kanina. So, yun.
Yes, sir.
Actually, maganda rin sa Urodynamics yung sphincter. Wala kasi tayo nun eh. Doon mo makikita yung...
Pwede nun eh. Tayo, yung sa atin yung na Urodynamics ng sa Medtronics. Kailangan lang kabitan. Although, yun nga, medyo hindi siya masyado
gagamit.
Ang ginagawa ngayon, sir, kasi marami daw muscles na na-detect yun. So, maraming artifacts. So, usually yung ginagawa nila, naglalagay sila yung nagtutusok sila ng pin.
Needle.
So, medyo nakakatakot yun.
Pero nabasa mo yun, Ernest, yung sphincter?
Yung sphincter dyssynergia, sir, ay yung ano?
Yung function, part siya ng urodynamics eh. May isa pang graph part yun.
Meron, sir. Pero hindi ko na EMG, sir, hindi ko na naaral eh.
Kasi dali lang intindihin yun eh.
Invasive.
Hindi, kunyari, normal sphincter function. What do you expect healing phase?
Dapat
Siyempre, padabi naman yung fluid sa bladder. Ano na nangyari? Ikaw, kung naihi ka, ano ba nangyayari?
tataas yung pressure, sir.
Tataas, di ba? So, pataas ng sphincter. Yung contraction niya, pataas ng pataas din. Yun lang naman yun. Kung napapaihi ka, di ba? Pinipigilan mo ngayon. Actually, doon mo makita yung dyssynergia. Pag nag-dyssynergia, contract, mag-relax. Contract, relax. Ganun lang naman yung dyssynergia. So normal, nag-i-increase yung sphincter function niya. Pag nag-void na, ano mangyayari dun sa graph na yun?
Bagsak, sir.
Relax ngayon siya, di ba? Pero sa dyssynergia, may contraction pa ulit on the voiding. Yun yung pinaka-function niya eh.
Pwede mo rin i-test yung patient's continence.
Continence din.
EMG. Kaya yung yung measure. So, yun yung doon.
Variable yung
kumbaga pag nag-leak,
ng EMG eh. Tapos nakita ko yung variable dun sa EMS natin na sphincter. Meron din yung invasive na needle. Kumbaga, yung equipment natin ready for urethral, ready for EMG.
Yung pinaka-important ngayon actually yung urethral pressure. Yun yung binibigyan nila ngayon ng weight, yung urethral hindi masyado ngayon, sir, yung sa EMG kasi nga si EMG marami siyang artifact kasi pwedeng maramdaman din nun yung bladder contraction, lahat. Pero technically EMG measures your muscles supposedly, so yun yung mga pag pinakigil mo yung patient, alam mo kaagad pwede siyang magkaroon ng continence or eventually para mga ganun. So yun yung function niya.
Actually, may pang practical use yun eh sa post-radical prostatectomy, diba? Kasi syempre affected ang sphincter dun. So, kaya nga naroon na incontinence ng patient. So, dun mo makikita kung is ang ano niya, sphincter pressure. Sabihin, may chance siya magiging continent later on.
Yes, sir.
Lagi may incontinence ang post-radical, di ba? Prostatectomy. So, maganda rin yun, pa post-radical, meron siyang na testing na urodynamics. Kung nakakaroon ng improvement, at may pag-asa yung pasyente na magiging incontinent. Yun. May mga practical ano rin yan uses siya.
Ernest, how many uroflowmetries do you have to do before you start urodynamics?
Ano yun, sir? How many uroflowmetry?
Para maging sabihin mo, sige, mag-urodynamics. Pwede na ako mag-start mag-urodynamics. Patient, kunyari, nakaschedule na si patient. Hindi siya in retention yung usual patient. Nakaschedule for urodynamics. Ilang beses ka magpapa-uroflowmetry? 1, 2, 3. Ilan?
Siguro, sir, pwedeng 2, sir. For confirmation. Sa initial uroflowmetry.
Bakit?
For example, sir, kung sir yung for example, may post-void residual ganun dun sa initial mo, or I mean, paano ba? Small volume lang yung output niya, and then mataas yung post-void residual. So, pwede mo i-confirm on the next uroflowmetry kung yun lang talaga yung kaya niyang i-void at that at the time.
Okay. Usually dapat at least 2 or 3 times. 2 hanggang 3 times, no? So hindi siya pwedeng isa lang kasi most of the time it's not a good representative of his daily yung parang yung routine niya na umihi. So you have to get the average of these 2 or 3. So usually yung una, uroflowmetry mo siya, and then siguro antayin mo muna ulit mapuno, tapos kasi dadating yan, kunyari, Doc, naiihi ako, uroflowmetry mo na. Second, pupunuin mo muna ulit, tapos papaihiin mo na siya ulit.
Yes.
And then yung last na uroflowmetry mo is already with pressure. Yun yung kasama na ng urodynamics mo. So yun, doon mo ma-assess na kung it's good representative of the yung usual niya na urine flow, no. So hindi siya pwedeng isa lang kasi minsan mali. Minsan kasi maraming pwedeng yan, parang biglang nahihi, mabagal lang ihi, or kulang pa pala, hindi pa pala punong-puno pero na-excite siya, 'di ba? Tas konti lang na ihi, parang gano'n. So, doon kasi tapos i-check mo pa pati yung residue. So, maraming factors ang kasi hindi ganoon ka accurate si uroflowmetry. Tapos ano ang usual itsura ng uroflowmetry ng patient na obstructed? Doon sa mga pinakita mo kanina. Diniscuss mo yung plateau, diniscuss mo yung
usually, sir,
yun?
plateau, sir. Pwede yung plateau.
Plateau? Okay. Ano pa?
And pwede yung
may word din sa piano yun sa piano.
Staccato.
Yun, staccato. So parang up and down siya, no? So kasi ang nangyayari, how do you explain staccato?
Ano nga ba yun?
Bakit nag-i-staccato? Kasi yung plateau pwede hypocontractile bladder lang yun 'di ba? So, hindi siya automatically. Pero yung staccato, pwedeng mas more of obstructive. Bakit? Siya, pwede nyo siyang tulungan para lahat tayo.
Nag-abdominal straining kaya parang nag-up and down yung sir, sa graph.
Ayan, umiiri-iri. So, pag umiiri siya, tumataas yung flow. Pag nawala, syempre, pag tumigil na yung valsalva niya, bababa ulit yung flow. So, yun yung process nung tinatry i-overcome nung abdominal pressure, yung pressure na humaharang doon sa ihi. Okay? So, yun yung usual na makikita mo. Okay?
Yes, sir.
By the way, pag nag-release kayo ng urodynamics na result, how do you ano yung mga sequence of paano ba yun? Paano mo siya i-explain? Paano mo siya tawag dun? Release yung results. In terms of yung activity ng bladder, ganyan. Dapat parang may discussion yun di ba?
Usually,
parang yata nabanggit yun.
Like for example, pwede ka mag-start dun sa during feeling phase, as in
di-describe mo lahat yun.
Or
sige, mag-sample mag-relay ka ng result. Kunyari, BPH with DM, parang kanina. During the feeling phase, patient, sige, describe mo. Practical yan Kailangan alam mo na kung paano mo siya i-relay, di ba?
So, ayun sir, example, during
a volume of ganyan.
The volume infused was, for example, 600. However, there was no sensation to void that ganun sir, walang basta step by step sir.
Oo nga, ano yung mga steps mo? From the feeling to the voiding to the pero alam mo yun, dapat release ka ng urodynamics, meron kang sequence na sinusundan. Actually, ang tawag doon?
Kwento mo lang sa events.
Kwento mo lang naman kung yung events, basically.
More or less, yung sa mga yung sa St. Luke's, meron nag-meet sa akin ng urodynamics results galing St. Luke's. Ang haba, as in, pati yung history ng patient nandun. Basta as in, kwento talaga para siyang nobela. Other than the graphs, as in, ikukwento niya, pati, kunyari, anong nangyari at this point, ganyan-ganyan, natanggal yung catheter, ganyan-ganyan, habang nagpapavoid, ganyan. Kasi di ba nangyayari yan habang nagpapavoid kayo, natatanggal yung catheter. So, kaya kulang. So, usually, try your best. Usually, yung ginagawa namin dun sa Fatima, pag nagkakaroon ng ganon, pinababalik talaga ulit namin yung catheter, tapos tinatry ulit gawin yung yung pressure flowmetry, yung mismong merong pressure studies. Kasi yun yung pinaka-importante, lalo na kung yung patient for TURP, for so for an obstruction. So pag hindi mo kasi nagawa yung part na yun, although naiihi niya yun, na ibig sabihin malakas yung pressure. So pwedeng yun na yung mo na rin, sign mo na makakaihi itong pasyente to.
The suggestion ko lang, dun sa results, go ka ng meron ka ng checklist na miss out. Yung yung di na ikwento. Checklist, tapos sundan mo lang yun. Gawin ko ng kwento, strong contractility, low flow. Sundan mo lang yung checklist na yun. Para hindi ka mawala. Susundan mo lang yun na yun. Para pag ka na, bigbigay ka ng result, Hindi ka mawawala kasi meron ka ng guide, basically.
Yes.
Yun. Ano pa?
Yeah.
Mahirap ang Urodynamics.
Um,
Pero kailangan kasi,
Isa mahirap din
kailangan mo
yun.
talagang gustuhin siya bago
Yes,
mo
sir.
talaga siya maintindihan. Si Mark, yan yung subspecialty eh. Si Gamo.
Gamo. Actually.
Anyway,
Wala.
meron akong lecture sir dati, di ba? Ewan ko sila, ikaw ba Rom pinaka-junior no? Nung nag-lecture ako nun? Yung walkthrough ng basic Urodynamics.
Hindi, ano na siya nun?
Yung sa same talks comment ako yung kay Marcos Drake tsaka kay Abraham. Pero
Meron yung, kailan ba yung 2000?
Nasa labas tayo noon, ni-lecture.
2016 ko yung ginawa, nakuha ko yan sa ICS. Nag-masterclass ako tapos nag-echo yata ako.
Echo lecture. Alam ko yun.
Kasi yun. Para
Andiyan ba yung lecture mo?
nyo gamitin yung Urodynamics talaga.
lecture sa amin nung isang araw si Dr. Panganiban.
Ano na?
Lecture sa amin nung isang araw si Dr. Panganiban din ng Uroday.
Okay.
Kasi nagbabasa sa TikTok sa haba ang alam mo sa kanya. Pero same din eh. Parang in-echo lecture kay Abrams eh.
Okay.
Sinulat nila. Yung book ni Abrams nandun. Tinag ko na sa kanila eh. May lang mahaba nila. Yung diniscuss nila yan, 3 days kami.
Talaga?
3 days yun. Hindi natin naka-tricks.
Hindi, yung sa Bristol, yung sa St. Luke's, 3 days nila kami nag-masterclass.
Yun hindi, meron dun. Ayoko nun eh. Hindi, ang gusto ko kasi yung ni-lecture ko before eh, nung parang kung paano mag-set Urodynamics machine, ano yung pag-troubleshoot, kasi yun yung mga i-expect nyo na mangyayari during doing the kasi marami kayong na-encounter. Paano nyo masasabi na mali tracing na to? Ano yung quality check nyo ng tracing? Kasi pag mali yung tracing nyo, hindi rin yung result. Diba? Tama yung tracing nyo. Paano nyo masasabi na tama yung tracing nyo? Kasi madali naman talaga siya. Pag sinabi mahina yung PDET, hypocontractile bladder. Pag mataas yung PDET habang umiihi, obstructed siya. 'Di ba? Yun lang naman yung yung parang basic niya eh. So, ang tanong doon, tama ba yung tama ba yung nakukuhang measurement nung inyong machine? Paano kung mali? Di mali din yung interpretation nyo. Mali yung mabibigay nyo na treatment. It's very, very important that you know how to troubleshoot, you know how to set up the machine, and you also know how to check your tracing, and you know how to interpret yung importante doon urodynamics na technically sa studies niya. Pero yung mga iba, yung for the exams, actually, ang importante doon sa part na mga diagnosis. So, yun, yung mga sinasabi mo na huli. Which is, madalas, konti lang naman din yun eh. Pero, ang use ng Urodynamics, ang isa sa mga importante yung kunan. Tsaka yung mga how to prepare the patient bago nyo siya Urodynamics. Ano bang kailangan yung makuha sa kanya? Naisip nyo lang pa Urodynamics pad. So, kasama doon, syempre, balik tayo sa basic, history PE, ano yung medications na tinitake niya, etc. Mga ganun ba? Tapos, importante, bakit minsan hindi mo na kailangan mag-Urodynamics, bladder diary pa lang, pwede na. Kasi marami ka ng information na makukuha doon. Tanong ko sa iyo, ano pa yung mga information na pwede pang makuha sa voiding diary? Kasi hindi lang naman yun yung capacity, hindi lang naman dalas siyang umihi. 'Di ba? Yung mga ganun. So, makukuha na agad, baka mamaya pa lang, alam mo na kagad na ganito yung problema ng pasyente. Diba? Confirmation, well, yes, confirmation si Urodynamics. Kasi siya lang naman talaga yung pwedeng may metrics with regards to to the lower urinary tract function. Kung may dysfunction yon, mami-measure mo siya to the point. Pero yung ibang sa voiding diary, magkakaroon ka na ng idea. So, kumbaga si Urodynamics talaga do time is the last of all for all the parang sa diagnosis ng lower urinary tract symptoms. So, pero siya yung pinaka-accurate. Siya supposedly ang pinaka-accurate. And how can it be accurate? Dapat tama nyo yung ginagawa. Kasi kung mali din yung lalabas, inaccurate. So, yun. We can go on with all that, pero you will not understand the principle behind it. Kasi kailangan maintindihan nyo, ano muna yung mga pressures na yan? Para saan yan? You should know the normal first. Yeah. Anyway.
Walang panel, di ba? Sa orals.
Meron. Yun? Functional. Female urology, doon pumapasok yun, yung functional urology. Yung sa akin nga, kakaiba eh. Hindi. Tama. Nag-umpisa siya, meron siyang prostate cancer. Tapos na radical prostatectomy. Tapos yung nga incontinent. Basta ang haba, tapos hanggang sa pumasok sa na-stroke. Ano yung mga ini-expect mo na basta ang haba nun. Ganun na yung sa akin nun eh. So, yun pala, fistula pala. Para iba-iba, kakaiba eh. Basta yun eh, parang usually yung pag-orals, parang it starts from a very simple case, tapos gagawin nilang komplikado. Parang ayun. Babalik ka lagi dun sa basic, yung yung mga go back to the history, kaya kailangan yung mga papel, may pencil sa ka to take note. Yan. Anyway, pag may time din, next time, try ko, i-lecture din ulit sa inyo yung walkthrough nung how to do it right ng urodynamics.
Yes, sir.
Yes, sir.
Yes, sir.
Okay.
Announcement lang for Friday. Sponsor kasi tayo sa Friday, AstraZeneca. Actually, may lecture daw si Doc Penny. So, sila kung pwede daw 8 o'clock. For Friday.
8 ng gabi.
Tapos may journal club. May medyo mahaba daw yung 45 minutes daw yung So if okay lang sa inyo, i-talk lang tayo.
Anong topic?
Ano to sir sa kanila? Gosrelin.
Gosrelin, Soladex sir yan.
Zoladex. Okay.
May bumalik na sila sa market eh. Actually sila yung inaayos ko kasi gusto talaga nilang kunin yung lunch symposium nila sa atin. And kung sana i-maintain para next pag inayos nila Ralph, committed pa din sila for Kaya lang nag-reflect kasi na wala tayong tinutulong eh. So ngayon nila kahit mga 2 drug a month. Basta willing nila i-maintain yung next year. Mahirap na din kasi kumuha sir. Actually ang lunch symposium talaga natin biomed. Kaya lang sila lang yung may power dun sa golf eh. Nilipat ko sa golf yung biomed. Pwede sa golf. So, as possible, ma-maintain Noladex for so pagbigyan natin sa mga gamot. Sa Friday, may speaker nila si Doc Benny.
Sige, pa-isa-isa, pwede na.
Ano sabi sir?
Sige na, pa-isa-isa lang, pwede na.
And then lunch potion. Ano to iba? Parang nawala. Tapos ngayon nagpapalakas. Laging every month to nagbibigay sa atin. Ng mga pakain. Yan lang naman for the announcement.
Yung sa natin last year, evaluation, nagawa na ba yun? Lahat ng consultants and
Pirma na ni Dr. Uy, sir. Nagawa na namin kayo.
Pirma na? Nagawa na yun? Okay na.
Namin, 3 days after the deadline. Finila pa namin ni Ryan tsaka ni Ernest. Tapos
Inasa na namin.
Okay.
Sorry sir, pinilma namin kayo lahat.
Oh, okay. Thank you.
Ito pala.
Namang kwenta yun eh.
Yung ba yung performance-based, yung tinext sa akin ni Ryan? Yung ba yun?
You have to go talaga yun.
Iba pa yun.
Iba yun, sir. Iba pa yun.
Daw yun, sir.
Kailangan nyo talagang pulpahan yun, sir. Is para sa performance.
Pera yun, pera.
Si Dr. Del Rito, wala pa.
Sige po. Sana ako bukas.
Hey, sir. Nagparamin si sir.
Bukas, sige.
So, bawal i-forge yung sa performance. Pirmahan yun.
Baka pwede naman.
Bukas na ako, bukas.
Okay po, sir.
Yes, sir.
Ernest, meron akong removal ng defective catheter.
Yan naman, sir. Baka balo na naman.
Lalaki
Sige,
naman
sir.
to. Meron na naman.
Mahirap yan. Ultrasound guided yan.
Oo nga eh. Negative ang rapid.
Negative.
Yes, sir.
Si Boss Napo ba? Si Boss Napo na Urody ba yun bago itulip?
Hindi, sir.
Si Boss Nap na operahan?
Ilang tulip.
Kailan?
Yan, Carl.
Last week, sir.
Ganun ba? Oh.
Ayaw sumakay ng ambulance, sir eh. Ako yung sumunod. Doon sa likod ng pick-up sumakay, nakahiga siya.
Ayaw na ambulance.
Teka.
Tagal na cutter.
Oo, sir.
Tagal.
Maganda yung kwento ni Ralph. Bukas na lang naka-record to eh.
Okay. Sige.
For 11 eh. Nandiyan ako.
Pwede nyo naman i-off yung record eh.
Pwede naman.
Recording.
Magugulat ka.